So let's continue the discussion on renal tubular acidosis. We have seen part of it. Today will be the last session of renal tubular acidosis. And later on we are going to take up water metabolism and polyuria followed by electrolyte abnormalities. So that completes acid-base disorders, renal tubular acidosis, polyuria and water metabolism, and then of course the electrolyte imbalances. So last time I have shown you this slide, and we have the features of renal tubular acidosis are obviously it is a metabolic acidosis with decrease in the bicarbonate and decrease in the pH and a secondary decrease in the carbon dioxide also. Okay, so it's a metabolic acidosis, and second thing is it is a non-anion gap metabolic acidosis. And third thing is there is a hyperkalemia and positive urine anion gap. 1, feature 2, feature 3, and usually hypokalemia. In some types it is hyperkalemia. That's what we learned. So what are the types we have? The proximal RTA, also called the PRTA. Earlier days it was called type 2 RTA. Distal RTA, which is called the type 1 RTA earlier. Now today the terminology is PRTA, DRTA, hyperkalemic RTA. So we don't use type 1, type 2, type 4 like that. So anyway, just to give you an idea what is type 1 and type 2, I have typed here. Proximal PRTA or distal DRTA, hyperkalemic RTA, voltage dependent RTA, and a mixed form, which is earlier called type 3, no more that classification is used, but remember when the features of both P and D are there, it is a mixed type. Okay. Out of these, we have already covered the two things, the proximal RTA and the DRTA we have covered. So let us see these two things today and also see the algorithmic workup, how we go about in a patient systematically. So hyperkalemic RTA, also called the type 4 RTA. Here, the usual feature of RTA is hypokalemia, low potassium. But here, instead of low potassium, we have hyperkalemia. So a defect in the regeneration of bicarbonate secondary to urine ammonia. So what is happening? Urine ammonia secretion or formation is less because there is inadequate ammonia there. So naturally the bicarbonate cannot be claimed unless the ammonia is formed. The hydrogen ion cannot be excreted, and in turn the bicarbonate cannot be claimed back. So the regeneration of bicarbonate in the cytosolic cytoplasm is affected. So that is regeneration of bicarbonate. The defect is regeneration in the bicarbonate secondary to inadequate urinary ammonia. So this is the commonest cause of this type 4 RTA or hyperkalemic RTA is hypoaldosteronism with hyperkalemia. You know, hyperaldosteronism will be excess sodium and water, and patient will be edematous and all. The absence of aldosterone, the mineralocorticoid receptors are not stimulated, so much so sodium resorption will not take place. So the cation exchange between sodium and potassium and sodium and hydrogen doesn't occur. So normally what happens, the sodium is exchanged against two cations, hydrogen and potassium. Since the sodium is not claimed back due to absence of the mineralocorticoid activity or resistance of the mineralocorticoid receptor, hydrogen is not exchanged for sodium, neither potassium is exchanged. So hydrogen is retained in the blood and potassium is retained in the blood. Please mute your microphone. This is acidosis. Who is that? Who is opening the microphone? Please don't do that. So, when the sodium is not exchanged because of the inability of the ammonia secretion, sodium is not claimed back in hypoaldosteronism. The mineralocorticoid receptor is not acting and sodium is not allowed inside. So hydrogen is retained, that leads to acidosis, and potassium is retained, that leads to hyperkalemia. This is a hyperkalemic acidosis. That's what we know already. So let us see what are the other features. Hyporenism. So low renin. Low renin means low aldosterone, and low angiotensin 1 and 2, hyporenism, and defects in the RAS system or in the aldosterone pathway. These are the common causes. High aldosterone or normal levels may be seen if there is resistance. So this is aldosterone deficiency in this condition. Whereas here aldosterone is normal or increased, but it is resistant, just like the insulin resistant. The receptor is not amenable to the aldosterone present. So body thinks more aldosterone will be required, it secretes more, but even then the receptor is not opening. And that is what is called the aldosterone resistance. Or sometimes we use drugs to block the aldosterone receptor, either a MR receptor blocker or an aldosterone antagonist like spironolactone, amiloride or triamterene you use, then naturally the aldosterone receptor is blocked by the drug, so much so sodium resorption doesn't occur. Diuresis occurs along with sodium, water also goes. But in the process, potassium is retained and acidosis occurs. So here is a condition wherein there is acidosis and hyperkalemia together. The acidosis and hyperkalemia are secondary to either aldosterone deficiency, either because of renin deficiency or in the RAS pathway problem, or aldosterone deficiency occurring due to the diseases of the adrenal gland, or the aldosterone is normal but the receptor is not responding, which is called the aldosterone resistance. Sometimes we use drugs also to block the aldosterone. So three things: one, aldosterone deficiency, either in the biochemical pathways or in the gland itself, adrenal cortex, or aldosterone is resistance is there in the receptor level due to various conditions, or you are using drugs which will block the aldosterone. Any one of them will excrete sodium and excrete water and produce dehydration, have hyperkalemia, and have high hydrogen ion in the blood, which is metabolic acidosis. Okay. Now, hereditary hyperkalemia RTA, there is a condition called, there is a hyperkalemic RTA which occurs due to the hereditary condition. There is an aldosterone synthetase is deficient, aldosterone synthesis, or it could be pseudo aldosterone deficiency also. Drugs that are used: potassium sparing diuretics, antibiotics, NSAIDs, cyclophosphamide, tacrolimus, ACE inhibitors, heparin, low molecular weight heparin. So these are some of the drugs which are associated with hyperkalemic RTA or type 4 RTA, which is very different from type 1, which is different from PRTA, which is type 2, DRTA, which is type 1, wherein we have hypokalemia, here we have hyperkalemia. So how do I distinguish? So this is this table here: normal, early primary, late primary, early distal, late distal, and type 4 RTA. Look here the features here. The potassium is low and low in the two types there, and whereas here it is high. Potassium is high in this case. Osteomalacia, now osteomalacia is a feature in primary, osteomalacia is a feature in the primary, it is a feature in the distal, but it is not a feature in the type 4 RTA. Nephrocalcinosis is a feature of the distal, absent in the primary, and also absent here. Urinary citrate, normal in primary, low in distal, and normal in this. If the urinary citrate is low, and then you have nephrocalcinosis and renal stones, and you are bound to be looking at DRTA, where the acidification is affected, but not to a great extent. The pH is still higher than 5.5. Okay, so whereas here the pH is much lower, here this is the normal pH. Here the pH is much lower in the late stages. So here also the pH is much lower because of the receptor blocker. In the ammonia, normally there's no problem. Here also there's no problem. Here urinary ammonia is low, and that is the mechanism. Here also ammonia excretion is low, whereas here it is the bicarbonate reabsorption that is the problem. So you understand that way, and we will go further and you will know better about these things. So what are the various causes of hyperkalemic metabolic alkalosis, hyperkalemic RTA? What are the various causes? So there could be an angiotensin converting enzyme inhibitors normally used in the treatment of hypertension, or ARBs, angiotensin receptor blockers, or impaired aldosterone metabolism, or aldosterone receptor blockers, okay, or drugs which interfere with the aldosterone action there, like triamcinolone, amiloride, trimethoprim, pentamidine, or there is an impaired renin secretion from the juxtaglomerular cells. Any one of these mechanisms, starting from how can there be a renin secretion impaired? By these drugs like NSAIDs, beta blockers, cyclosporine, tacrolimus, diabetes, and elderly people. So, number one cause, renin, low renin, ACE inhibitors, ARBs, paired aldosterone metabolism, aldosterone receptor antagonist, and potassium sparing diuretics. That they are called the sodium channel blockers. In a way, sodium is not allowed inside, sodium is excreted and potassium cannot go. They are called the potassium sparing diuretics, otherwise called the sodium channel blockers. Here, the potassium sparing diuretics are here: spironolactone, eplerenone, and drospirenone. Drospirenone and eplerenone and spironolactone are aldosterone receptor blockers, and sodium channel blockers are amiloride, triamcinolone, trimethoprim. They don't do anything with the potassium but block the sodium absorption. Indirectly, they retain the potassium. So, these are the various causes of hyperkalemic RTA, also called the type 4 RTA, which is also quite common compared to the congenital or hereditary forms of these do occur in adults, whether the more pediatric diseases. This is where which you will encounter more frequently as internal medicine and pediatricians. They encounter proximal RTA and distal RTA more. Okay. Now, how do I treat this particular condition? So if just recapitulate the mechanism here, this is the MR receptor. The MR receptor is stimulated. It has two effects. One, it acts on the sodium channels to allow the sodium, and also it allows the potassium to go out. Along with the sodium, water also is reabsorbed. AQP, aquaporin 2 also is open. ENCA, that is the sodium absorption channel, is open along with the aquaporin channel by the action of mineralocorticoid. This causes sodium inside, the cell will be more, water also will be more, the water diffuses this side by another aquaporin channel on the other side, which we'll see later on, but the sodium is exchanged with an ATPase, which is NAK ATPase, where sodium is brought in and then potassium is sent into the cell, from then it is sent into the urine. This is normal. But what is happening here? There is a block here. That means either the mineralocorticoid receptor is blocked, or mineralocorticoid receptor is insensitive, or the hormone which stimulates the mineralocorticoid, the aldosterone is low or hypoaldosterone. In all these conditions, this channel is not open. This channel, of course, is not open. This channel is not open. Sodium goes down, water goes down, sodium and water. Potassium is retained here in this. And because sodium and is exchanged to both K and hydrogen, hydrogen also is retained. That causes the acidosis, hyperkalemic acidosis. This is looking at the diagram also. So the defect can be one, aldosterone problem. Two, it could be NAK ATPase dysfunction secondary to aldosterone. Okay. It is not that there is a tubular defect here. It is a receptor, mineralocorticoid receptor defect that is there. So how do I treat? Any drug which is retaining potassium, I should stop. and restrict dietary potassium like fruits and fruit juices and potassium containing salts and other things. Control hyperglycemia, treat the acidosis, and treat the volume depletion because there is a lot of water is going down here, there's dehydration. Treat the volume depletion. And then use loop diuretics. What do they do? They absorb the sodium and excrete the potassium. Unlike these drugs, these sort of drugs like aldosterone antagonists and all, they excrete the sodium and retain the potassium. Whereas the loop diuretics, they are just opposite. They excrete the potassium and retain the sodium. And also mineralocorticoid supplementation may be useful in case there is a low aldosterone is the reason. And K-exilate is another substance which can be used. The treatment is drug stopping drugs, offending drugs which cause potassium retention. Dietary potassium should be restricted. Hyperglycemia and metabolic acidosis, volume depletion to be corrected. Use of loop diuretics. Use of fludrocortisone or mineralocorticoid. Use of K-exilate, which is a potassium absorption binding agent. Okay. Now, the next type of RTA is voltage dependent RTA. It is a rarer form of the RTA compared to all the four. It's not very common. Just quickly a few words about that. You will learn about it. What is this? Here the RTA is occurring because of the voltage dependent hypercalcemia, hyperkalemia RTA. Here the sodium, the small number of patients with DRTA have increased in the potassium rather than the hypokalemia. Normally, RTA, distal RTA is having hypokalemia. In some patients with distal RTA, there can be hyperkalemia, and they are these people, voltage dependent one. What is this? There is distal tubular sodium delivery is not there. Suppose this is the distal tubular cell, DCT, and then this is the lumen, and this is the blood. Here, the sodium is not available for the potassium to be, sodium to come in and potassium to go out. There is low sodium presented, and the potassium is sitting here to get exchanged, but there is no voltage gradient. There is no voltage gradient because the sodium itself is so low. The cation is low there. Sodium. There is no one to exchange for the potassium. Potassium is waiting on the other side of the membrane, and hyperkalemia in the blood results because of poor presentation of distal tubular sodium delivery. That is lack of voltage gradient. What are the causes why sodium is coming into the DCT less? Because a favorable transepithelial voltage gradient cannot be maintained, forcing retention of both K and H are retained, sodium being very low here in the tubular lumen. Voltage dependent distal RTA is confused sometimes with the previous condition, the hyperkalemic RTA, which is the mineralocorticoid receptor problem or mineralocorticoid blocker use or renin conditions or ACs and things like that. This has got nothing to do with the mineralocorticoid RAS mechanism, but here there is less sodium in the lumen, so potassium and hydrogen cannot be exchanged. Type 4 hyperkalemic RTA maintains their ability to acidify urine in response to an acid load. Unlike the other RTAs, here you give an acid load, the acid is being excreted. So extra acid load is shut down. But the main problem is sodium delivery to the tubule is less to the distal convoluted tubule. Now, stepwise diagnosis of renal tubular acidosis. Just like the stepwise diagnosis of acid-base disorders we have a stepwise diagnosis. Number one, establish non-anion gap metabolic. First of all, if you want to diagnose RTA, it must be an AGMA. It is not an AGMA or respiratory acidosis. That is for sure. The second one is estimate the urine anion gap, which will be positive in RTA, which will be negative in renal causes of NAGMA. Determine the urine osmolar gap. That is, measure the urine osmolality with the osmometer and also calculate the osmolality. So measured osmolality minus calculated osmolality. Measured minus calculated is the delta anion, delta osmotic gap. Determine the urine pH using pH meter. And then bicarbonate loading test you have to do urine to blood carbon dioxide gradient. What is the carbon dioxide in the blood? PCO2 in the blood is 40. What is the carbon dioxide in the urine? PCO2 urine, you have to see, and the gradient, let's say if it is 20, and the gradient is 20. So this is what is called the urine to blood gradient. So what you have to do is urine you have to write on the top. Urine carbon dioxide gradient is blood carbon dioxide, blood PCO2 40, urine is 60, gradient is 20. Okay, so that is the urine carbon dioxide gradient there, and then that's how you do that. You measure the PCO2 as usual in the blood, and also measuring the CO2 concentration of the urine is not that easy, because this is this you require to collect it very carefully, the urine, because there is atmospheric carbon dioxide, and that gets into the urine. Normally, when you pass urine, as the patient passes urine, the carbon dioxide in the atmosphere contaminates the urine. So there is a special method of collection and analysis of the urine carbon dioxide is required, not done in many labs. But then this is a useful tool to differentiate different types of RTAs. And this can be done very easily. Fractional excretion of bicarbonate. I will show you what is fractional excretion of bicarbonate. Fractional excretion of phosphate also is important, and transtubular potassium gradient, TTKG, and finally the furosemide test. These are the higher tests of renal tubular acidosis. Diagnosis: first confirm that there is NAGMA, and confirm that there is a positive urine anion gap, and look for the osmotic gap or osmolar gap in the urine. Delta osmolar gap you calculate to see the osmotic substances in the urine, and look for the urine pH. Is it less than 5.2 or more than 5.2? Is important. Bicarbonate loading test, and also look after bicarbonate loading, looking at the fractional excretion of bicarbonate, looking at the urine blood carbon dioxide gradient are two tests. Likewise, then you have to do the phosphate excretion, that is fractional excretion of phosphate, and transtubular potassium gradient, TTKG, and finally the furosemide test. I'm not going to go into the details of these things, but I just showed you that these are available. I'm going to circulate 4 PDFs. One is, of course, our presentation, the first one. Second one is about pathophysiology. Third one is about the various types and diagnosis. And the last one is about evaluation, the fourth PDF, which contains the details of how these tests are conducted and when you have to conduct. So that is a little beyond the scope of this presentation, but nonetheless, those of you who wanted to know them, I'm going to circulate 4 PDFs. The first is our presentation, complete presentation. 2 is pathophysiology. There are various cells, what happens, and each cell, the receptors there. I showed you all the diagram. That contains that. The third one is diagnosis and differential diagnosis and clinical features. And the fourth one is the algorithmic evaluation and also the stepwise evaluation here. These 4 papers I'm going to right now, after the presentation is over, I'm going to share with you, and you can have a look at that. Of course, the video of today's presentation as well as the 2 previous presentations is also they're also available for you to review the topic. This is such an interesting and a difficult topic. I urge you to go through once again so that it sticks to your brain. Okay. So how do I calculate the urine osmolar gap? Just like the plasma osmolar gap. What did we do? In plasma osmolar gap, we measured the osmolality with the osmometer, and we calculated the osmolality. Measured minus calculated is the osmolar gap. Here, we are not measuring plasma, we are measuring the urine osmolality. For plasma osmolality measurement, we have plasma osmometer. Here we have urine osmometer. And for calculation, there we were using 2 into sodium plus 1 divided by 1.8 plus glucose divided by 18. This is what we were using there for the plasma. Here, similar one only, slightly different. Instead of using blood urea nitrogen, we use the converted urea itself in the urine and divided by not 1.6 but by 6. And glucose, of course, the same, divided by 18. Instead of only sodium, there is an ingredient potassium also is there, and sodium plus potassium. Together, you take the total and then multiply by 2. Then that you get the calculated osmolality. So CO, calculated UCO, urine calculated osmolality, is equal to 2 times urine sodium plus potassium plus urea minus 6 divided by 6 plus glucose divided by 18. That gives you the calculated osmolality. Measured from the osmometer, and the difference is the urine osmolar gap. Then how do I calculate the fractional excretion? Any substance, fractional excretion, the concept is what is the concentration in the plasma and what is the concentration in the urine and what is the ratio of that. How do we know the concentration in the plasma? Substance X, let us say creatinine in the plasma. Okay, substance X is sodium in the plasma. Sodium in the plasma is sodium value and creatinine of the plasma. That is the concentration, sodium per unit creatinine. Likewise, this is in the plasma. In the urine, sodium in the urine by the creatinine in the urine. This is the urine concentration. Fractional excretion is the ratio of them. Sodium in the plasma by this is the creatinine in the plasma. This is the denominator. The numerator will be the urine. So what will happen? Urine in the, when you do the cross multiplication, urine sodium in the top by the plasma creatinine. So serum creatinine. So serum creatinine goes up by cross multiplication. And then the plasma substance, plasma sodium will come down. So nothing but this is the proportion of a substance in the urine compared to the proportion of the substance in the plasma. Why? Because we are talking about excretion. Excretion means urine should be the numerator. Urine should be the numerator. What is the proportion? Urine sodium by urine creatinine in relation to creatinine. Because the renal function affects various excretion of various substances. We always titrate against the urine creatinine. This has to be a ratio of that to plasma sodium by plasma creatinine. This is the ratio in the plasma. This is the ratio in the urine. We wanted to know the fractional excretion. A ratio of these two is the excretion. Neither sodium or phosphate or bicarbonate formula is the same. Only thing is you substitute that substance. Instead of sodium, you write bicarbonate. Then this becomes urine Na by urine creatinine into plasma creatinine by plasma Na. Because when you are cross multiplying, naturally these two get multiplied. That's what is this one, and these two get multiplied. Okay, by cross multiplication, urine substance X divided into plasma of creatinine divided by the plasma of the substance X, whichever you are dealing, into urine creatinine. So plasma creatinine is the top, urine creatinine is the bottom. Excretion is the problem. That is why we were looking at the urine of the substance. Substance in the urine is on the top, substance in the plasma at the bottom. This is called fractional excretion of sodium, of potassium, of glucose, of any molecule that is present both in the urine and in the plasma. There may be some substances which are not present in the urine. Then there is no point in doing this calculation. Whenever you do the calculation, the substance must be present both in the blood and in the urine. Then only you can do the fractional excretion. So fractional excretion of bicarbonate is essential. How do I do that? Get the urine bicarbonate, get the plasma bicarbonate, Plus they get the urine creatinine plus the plasma creatinine, urine bicarbonate into plasma creatinine divided by plasma bicarbonate into urine creatinine is called the fractional excretion. How is it important? We will see fractional excretion of bicarbonate, fractional excretion of phosphate, plus excretion of sodium in case of your aldosterone and all you require that. So these are some of the important things. For this RTA, these two are important, phosphate and bicarbonate. Now, the algorithmic approach. We are dealing with anion gap acidosis. We are dealing with metabolic acidosis. This is met acidosis, not respiratory acidosis. Met acidosis, immediately I do an anion gap first step and high anion gap, normal anion gap, which also called the hyperchloremic anion gap. Normal anion gap means bicarbonate decreased, but there is no other anion. So naturally to compensate, chloride has to go up. That is why hyperchloremic or non-anion gap acidosis. In this case, bicarbonate is decreased, chloride is normal. There is another anion which has come, like salicylate or keto acid or something, and that is why the anion gap has widened. Okay. Now, high anion gap, is it because of the kidney disease or is it because of the extrarenal? So suppose there is EGFR is reduced so much, then there is uremic acidosis that can produce high anion gap, or lactic acidosis, diabetic acidosis, starvation ketoacidosis, alcoholic acidosis, ethylene poisoning, ethylene glycol, methanol, salicylate. We know the mud piles. These are all the causes of high anion gap. Now, we have a normal anion gap hyperchloremic acidosis. We have to differentiate, is it renal origin, is it extrarenal origin? How do I do that? Looking at the urine anion gap. Urine anion gap in these conditions is negative. In these conditions, it is positive. Renal tubular acidosis, mild renal insufficiency is not the cause. If it is severe renal insufficiency, it causes anion gap acidosis. Here, at least 15 ml GFR is maintained. So, it is not the renal insufficiency causing acidosis. There is tubular defect which is causing this. In this case, tubules are normal, but filtration is a problem because of the urinary GFR being less than 15. Okay, what are all the causes of negative anion gap extrarenal origin? Diarrhea, very common. Ureterosigmoidostomy, pancreatic or biliary fistula, drugs like cholesterol. Now we are here trying to differentiate this condition further. So the first workup of the anion gap metabolic acidosis is we have to first of all identify that it is metabolic acidosis. How do I do that? Metabolic acidosis is characterized by low bicarbonate and low pH because both are on the same side, and also we have got the secondary variable carbon dioxide also is low here. Okay. Now, once you confirm that there is metabolic acidosis, you have done an anion gap, non-anion gap acidosis, anion gap acidosis. Anion gap acidosis, renal, extrarenal. The mud piles and the workup, and there you do a sort of plasma osmolality and all those things. History, plasma osmolality. When it is a non-normal anion gap or hyperchloremic acidosis, immediately urine anion gap is done. If it is extrarenal, urine anion gap is negative. If it is renal origin, urine anion gap is positive. But make sure that the GFR is there and kidney is not failing, but there is some other reason in the kidney which is causing the renal non-anion gap. If the kidney is failing, we go here to the renal origin uremic acidosis, which is an anion gap acidosis. Okay. Now, after having diagnosed that it could be renal origin non-anion gap, normal anion gap or NAGMA with positive urine anion gap, we are here and let us differentiate that further. So normal anion gap metabolic acidosis, suspected RTA. First thing I look at is hypokalemia. Is it hyperkalemia or hypokalemia? Because I know PRTA and DRTA are hypokalemia. And then voltage gated and type 4 are hyperkalemia. Okay. So first question is, what is the serum potassium like? If the serum potassium is hypokalemic, is the patient able to excrete bicarbonate quite well? That is called the fractional excretion of bicarbonate is more than 15%. That means the fractional excretion of bicarbonate is more than 15%. Means what is fractional excretion? We have seen fractional excretion of bicarbonate is urine bicarbonate into plasma creatinine divided by plasma bicarbonate into urine creatinine. If that is more than 15%, you are dealing with PRTA. If the fractional bicarbonate excretion is not 15%, but it is much lesser, then what is my serum bicarbonate? We expect in acidosis the serum bicarbonate to be lower. Yes, it is lower. Then you do the anion gap. If the anion gap is positive, of course it is distal RTA. So primary RTA is over, distal RTA is over. Suppose the urine anion gap is rather nearer to zero and not minus, of course, negative in the sense, just around the zero, then do the urine pH. If the urine pH is higher, then consider ammonia loading test and rethink the diagnosis. If the urine pH is more, this is not renal tubular acidosis, something else. Okay, let us say if the bicarbonate levels are not lower, but they're little normal, then load the bicarbonate. And naturally, when the bicarbonate is loaded, we expect the fractional excretion to go up. If it is going up, it is proximal tubular acidosis. Because anything more than 15% after loading also, it is PRTA. If it is not, you go back to this particular channel. So this is another way. This also I am going to present it. This is presented by this particular journal, Wachsner Journal on Nephrology, and these appear under the Creative Commons license, so you can freely use them. Creative Commons attribution license means you can use without any doubt while publishing or while. Of course, for teaching, you can use anything with a little note where you have got it like this. But if you want to publish also, these particular things can be easily used. That is what is called Creative Commons license. So what did I do? I found out that there is a NAGMA. And then immediately what I did the potassium. Potassium is low. So I am not dealing with type 4 and voltage gated. I am dealing with type 1 and type 2, either proximal or distal. How do I differentiate? I went into the fractional excretion of bicarbonate. Fractional excretion of bicarbonate is more than 15%, then straight away I am in the proximal RTA. If it is less than 15%, what is the bicarbonate like? Is it lowered enough? We expect in the acidosis to be lower enough. Then you do the urine anion gap and further decipher whether it is distal RTA or on other unknown causes. Okay. If there is a bicarbonate is not rather 22 or 21 like that, little depressed but not very much depressed, then do a bicarbonate loading. When I do a bicarbonate loading, if it is PRTA, excretion in the urine, fractional excretion will go up. In the PRTA, it will not go up in the other forms of RTA. This is how I differentiate between PRTA and DRTA, which are hypokalemic RTAs. Then we go to the algorithm for the hyperkalemic RTA. What if it is hyperkalemic RTA? Then immediately look at the pH. pH is always, urinary pH is acidic only. Is it less acid, more than 5.5, is still acidic only. Compared to normal urinary pH of 5.2, it is slightly more acid. That means it is voltage gated. If it is not more than 5.5, if it is less than 5.5, then you have to think of the type 4 for the hypoaldosteronism or aldosterone resistance type. So this is the T4 type. This is the V type, that is the voltage gated type of RT. So hyperkalemia, immediate answer is look at the pH. If the pH is is acidic, very much acidic, we expect that in the more than 5.5, that is, it is less acidic than it is in the hyperaldosteronism type. If it is definitely more acidic, that is the pH is not more than 5.5. So then if it is yes, that is if it is more than 5.5, that is the urine is less acidic. Then you are here, if the pH is not more than 5.5, that means it is less than 5.5. In such a case, you think about hypoaldosteronism and aldosterone resistance. So we can say here, what is the urinary pH? 5.5 is the cutoff. If it is less than that, less than 5.5, you write here. More than 5.5, you write here. So that there won't be any confusion. So that's the way you can write this table. They could have written like that, but anyway, it doesn't matter. We understand what they're saying. Now, I have to further work up a little bit about this. So, urine anion gap we have done. Urine anion gap negative, we know it is urine anion gap negative means gastrointestinal causes, or there is a acid intake. Somebody has taken some acid overload. Or if it is positive, that means we are suspecting RTA, we are looking at pH, potassium, and bicarbonate loading test. Okay, three things. So urine anion gap is positive, and then this is about hyperkalemic metabolic alcohol, not about hypokalemia. Look at the urine pH, look at the serum potassium, look at the bicarbonate. Urine pH is less than 5.5, potassium is normal or low, UB ratio, that is the carbon dioxide urine versus blood, is more than 20, fractional excretion is 10, more than 15%. We know fractional excretion more means proximal RTA, and UV carbon dioxide ratio also will be more than 20, and the urine is much acidic, less than 5.5, and serum potassium may be low or normal in the proximal RTA, because this is a hypokalemic type of acidosis species. The second one, the pH is more, potassium is still normal, bicarbonate, the urine and blood carbon dioxide is less than 5, Fe, fractional excretion is less than 5, you are dealing with type 1 RTA, because it is hypochloremia, and the FEH excretion, that is the fractional excretion of bicarbonate, is less than 5. If it is more than 15, it is here. In this case, here also it is, look here. Here it is 5 to 15%, and still it is more than 20, but the potassium is higher, and the pH is less than 5, 5.5. This type 4 RTA, and the remaining one is the voltage gated. So this very clearly differentiates between the 4 types of RTA using the parameters that we know. What are the parameters? The parameters are the urine anion gap, then the pH, then the potassium, and the bicarbonate loading, and the fractional excretion, and the urine carbon dioxide, blood carbon dioxide ratio. Depending on using these things, you can differentiate them into the type 1, the proximal, which is type 2, distal, which is type 1 classical secretory defect, type 4, which is the hyperkalemic type and aldosterone problem type, and hyperkalemic type 1 RTA, which is the voltage defect RTA. So this is the classical RTA, hypokalemia, and the voltage gated, there will be hyperkalemia. And that's how we understand the differential diagnosis based on the algorithms that I have shown. Now I have got one more summary table which tells you everything in one go. This table I prepared using all the 3 references that we have in our hand. Now, what are the 4 types? Prime, which is the PRTA, DRTA, hyperkalemic type 4 RTA, voltage gated less common RTA. Okay, what is the defect in PRTA? PRTA is a secretion of hydrogen and ammonia is the problem. In DRTA, bicarbonate reabsorption is the problem. Okay, and the aldosterone resistance and hypoaldosteronism, aldosterone resistance is the main problem here. And then here it is the low sodium in the tubule and impaired cation exchange and sodium presentation to the distal tubule is at fault. Causes hereditary associated Fanconi may be there. Here acquired causes, more important, drugs like amphotericin B and autoimmune causes like rheumatoid arthritis, SLE, those things. Here renin causes, aldosterone causes, and then the aldosterone excess in cases of resistance, diabetes, hypertension, CKD. These are all the causes of type 4 aldosterone deficiency rather. And then the obstructive uropathy and then potassium sparing diuretics could be the cause for the voltage gated also. Okay, and urine pH, you see it is very acidic here, and the same thing here. These two are acidic urine, these two are less acidic urine. Potassium, hypokalemia in the first two, hyperkalemia in the next two. Fractional excretion, of course, in the PRTA it is less than 15%, DRTA it is less than 5%, and voltage gated also less than 5. And hyperkalemia with the type 4 it is 5 to 10%. Urine, blood, carbon dioxide, more than 20, just like it goes with the bicarbonate excretion, and this is less, this is again more there, this is maybe this way or that way. Nephrocalcinosis is a feature of distal RTA, and renal stone formation is a feature here which is not there in the other three. Bone disease very common in proximal RTA, and then because the same carbonic anhydrase problem also exists in the bone also. Maybe they're here, absent in case of hyperkalemic type 4, very uncommon here. So this is another way. How do I treat? Large quantities of bicarbonate, small quantity of bicarbonate, mineralocorticoid, potassium sparing type of foods, low potassium foods, supplemental bicarbonate, stop offending drugs. Here, offending drug has to be stopped. Obstructive uropathy, if it is there, it has to be corrected. So this in a way is the summary of that. I just have one doubt here, whether this is the interchange, the first line. I think that the PRTA it is the bicarbonate and DRTA it is the secretion. Let us look at that in our this one. By putting the table, I might have put wrongly. I may correct it right now. I feel while looking at the table, that is, we'll go to that PRTA and see what is the primary defect and correct our table. Okay, this is a summary of it presenting, and let me now see the PRTA and DRTA. Proximal RTA, okay, defect in the bicarbonate resorption, proximal RTA, distal RTA, impaired ammonia and the hydrogen secretion. Okay, so I have to correct the table.